Welcome to the deep dive. We take source material, your protocols, your guidelines, and we really unpack them layer by layer.
Yeah, getting down to those crucial insights.
Exactly. And today, we're diving into something very specific but absolutely vital. It's the admission protocol for patients presenting with cellulitis,
Right, and this one's specifically outlined by Dr. Gregory Weir, a vascular surgeon, so it has that particular focus.
which makes it more than just, a standard hospital checklist. It feels like a detailed roadmap, really tailored for these patients, especially considering that vascular perspective.
It is. It's designed for thorough, safe, effective care right from the get-go, the moment they arrive on your unit.
And for specialist nurses, like you listening, getting the why behind each step in a protocol like this. Well, that's foundational, isn't it? For providing top-tier care, for anticipating what the patient might need next.
Absolutely. Cellulitis isn't always straightforward, especially in patients who often have those underlying vascular issues that Dr. Weir manages. You need a precise approach.
And this protocol gives that structure.
It does. It's about building that safety net immediately, identifying potential complications early, and setting up the right conditions for healing.
So our mission today is to go through this document meticulously.
Right.
We're not skimming. We're pulling out every key detail, exploring the clinical thinking behind it.
And talking about what it actually means for you on the ward, day to day.
We'll follow the structure of the protocol itself, starting with patient identity checks, then bloods, other investigations.
Medications, patient management strategies, some really critical ones in there.
Activity guidelines, then a deep dive into compression. That's a big one.
Wound care, too, if needed. And finally, discharge planning. What happens when they're ready to go home?
We're aiming for that really comprehensive understanding, going way beyond just a summary of the steps.
Okay, let's kick off right at the beginning. Patient arrival.
So, Section 1, patient identity. Seems almost too basic. Point 1.1 highlights it, though. Confirm patient identity on arrival in the ward or unit.
Yeah, and it even lists the methods. Hospital sticker, verbal confirmation from the patient, family confirmation, ID document, driver's license.
So why is this seemingly obvious step called out so explicitly right at the very start, confirming identity on arrival?
Because, fundamentally, patient safety underpins everything else. It might seem like common sense, but in a busy admissions environment, it's surprisingly easy for mistakes to happen if you don't have this hard stop, this mandatory check.
Right. Things are moving fast.
Exactly. And the consequences are serious. Wrong medication, wrong procedure, misinterpreting results for the wrong person. These aren't theoretical risks. They happen.
So stating it needs to happen on arrival, that's deliberate.
It is. It's before anything else happens, before you draw blood, before you give that first antibiotic dose, before you even start the assessment that guides the rest of the treatment. It's the absolute first safety gate.
And using multiple methods adds layers.
Precisely. Hospital sticker plus verbal confirmation or checking an ID, it makes the process more robust, less prone to error in a busy ward.
It's that non-negotiable barrier against error, right at the door. Then immediately after, point 1.2 shifts gear slightly. Welcome the patient and family and assure them that we are honored to help them. That phrase, honored to help them, it stands out in a clinical protocol.
It does, doesn't it? And it's important. We've just talked about physical safety with identity checks. This moves into psychological safety, establishing that therapeutic relationship.
How so?
Well, think about it. Patients coming in with severe cellulitis, they're often in pain, they're anxious, maybe they have complex health histories managed by specialists like Dr. Weir. They feel vulnerable.
And their families, too.
Absolutely. So greeting them warmly, showing genuine empathy and respect, and using that specific phrase, honored to help them. It's powerful. It's not just hospital politeness.
It's setting a tone.
It's immediately building trust. It reduces anxiety. It says, we see you as a person, not just a diagnosis. And that positive start can genuinely influence how they experience their care and how willing they are to engage with the treatment plan.
So right from minute one, the protocol establishes these twin pillars. Rigorous identity checks for physical safety.
And a compassionate, respectful welcome for psychological safety and building trust.
They're foundational. You can't really proceed effectively without them.
Spot on. You need both firmly in place before you move on.
Okay, good starting point. Let's just quickly recap those key takeaways from Section 1 before we move to the labs.
Will do. So for patient identity, the core message is confirm identity accurately using multiple methods like the hospital sticker or verbal check immediately upon the patient's arrival. It's the critical first safety step.
Non-negotiable.
Non-negotiable. And paired with that is the importance of a warm, respectful welcome for the patient and family, using language like honored to help them to foster trust and ease anxiety right from the outset.
Safety and trust established up front. Makes sense. Okay, with those initial steps done, the protocol shifts to assessing the patient's internal state. Section 2, blood tests. It mentions Lancet Laboratories, suggesting maybe a standard process there.
Yeah, likely the hospital's contracted lab or standard practice.
So this is the initial lab workup. 2.1 lists urea, creatinine, electrolytes, the UK panel. Let's break this down. Why these specific tests for a cellulitis admission? What are urea and creatinine telling us here?
Okay, urea and creatinine are our main windows into kidney function. They're waste products filtered by the kidneys. Assessing kidney function in someone admitted with cellulitis, especially if it's severe, is vital. Why?
Go on.
Several reasons. First, medication dosing. Many drugs we use antibiotics, like the ertapenem mentioned later. Pain meds, they're cleared by the kidneys. If kidney function is poor, the drugs can build up toxic levels. So we need to know the baseline to adjust doses if needed.
Right, avoid toxicity.
Second, the infection itself can sometimes hit the kidneys, maybe through dehydration or the body's systemic inflammatory response messing with blood flow. So checking gives us a baseline kidney status and helps us dose safely from the very beginning.
Okay, so safe prescribing and checking for organ impact. What about the electrolytes part? Sodium, potassium, chloride, bicarbonate.
Electrolytes are those essential minerals dissolved in body fluids. They're involved in, well, almost everything: fluid balance, nerve signals, muscle contractions, keeping the body's acid-base balance right.
And infection can throw them off.
Easily. If the patient has a fever, isn't eating or drinking well, or has underlying issues like diabetes or heart failure, imbalances are really common. Potassium levels, for example, are critical for heart rhythm. Sodium levels affect brain function. So checking electrolytes helps us see their hydration status, identify any imbalances that need fixing, and just gives a general picture of their metabolic state. How stable are they overall?
Got it. UK paints a picture of kidney function, fluid status, electrolyte balance, essential baseline stuff. Next up, point 2.2. Full blood count, or FBC. What specific insights does the FBC give us with cellulitis?
The FBC looks at the different types of cells in the blood. For an infection like cellulitis, the white blood cell count, the WBC, is usually the headline act.
Because that's the infection fighter count.
Exactly. The body ramps up production of white cells, especially neutrophils, to fight bacteria. So a high WBC count leukocytosis is your classic sign of the immune system responding. The actional number can give a rough idea of severity.
What if it's not high?
Well, sometimes in really severe infections, overwhelming sepsis, or in patients who are immunocompromised, the count might be normal or even low leukopenia. That can actually be a more worrying sign. And looking at the differential, the breakdown of which white cells are high or low can sometimes give extra clues.
So it's our objective measure of the body's inflammatory battle. What else in the FBC matters here?
We also look at hemoglobin and hematocrit, the red blood cell picture. Tells us about oxygen carrying capacity. Is the patient anemic?
Why does that matter for cellulitis?
Well, significant anemia might affect their overall stamina, their ability to tolerate the illness, and potentially impact tissue healing, especially if circulation to the limb is already a bit iffy. And then there's the platelet count.
For clotting.
Right, crucial for clotting. And remember, these patients are often immobile, putting them at risk for deep vein thrombosis, as we'll discuss. So knowing their baseline platelet count is important context. Very low platelets, though Weir, could flag a serious complication like disseminated intravascular coagulation in severe sepsis.
Okay, so FBC covers immune response, oxygen capacity, clotting status, all relevant pieces of the puzzle.
Yeah.
The last blood test listed is 0.2.3 C-reactive protein, CRP. What is CRP and how useful is it here?
C-reactive protein is what we call an acute phase reactant. Basically, the liver pumps it out in response to inflammation or infection anywhere in the body.
So it's not specific to cellulitis.
No, definitely not. Lots of things can raise CRP. But in a patient who clearly looks like they have cellulitis, the red, swollen, painful limb, a high CRP level, gives you objective lab backup. It confirms there's a significant inflammatory process going on.
So it supports the diagnosis.
It supports it, yes. But maybe more importantly, it's really useful for monitoring treatment response. As the antibiotics kick in and the inflammation settles down, the CRP level should fall.
Ah, you can track the trend.
Exactly. Following the CRP trend over a few days gives you an objective marker of whether things are heading in the right direction, alongside watching the patient's clinical improvement, less pain, less redness, less swelling.
It complements the clinical picture with a number.
Precisely. Objective evidence of response.
Okay, let's quickly recap the key takeaways from these initial blood tests.
Right, so the initial bloods, typically via Lancet Laboratory according to the protocol, give vital baseline info. The urea, creatinine, and electrolytes check kidney function for safe dosing and assess fluid electrolyte balance.
Crucial first step.
Then the full blood count reveals the immune response through white cells, checks for anemia with hemoglobin hematocrit, and looks at clotting status via platelets.
Got it.
And finally, C-reactive protein acts as a non-specific but valuable marker of inflammation and infection severity, particularly useful for tracking the patient's response to treatment over time.
Okay, beyond those standard bloods, Section 3 covers other investigations. Point 3.1 is really clear.
Yep.
Chest X-ray, duplex Doppler, magnetic resonance angiography, computed tomography angiography, and computed tomography pulmonary angiography are only done on specific requests from Dr. Weir.
Yeah, that immediately signals these aren't routine for every single cellulitis case.
So why the physician gatekeeping? Why aren't they just standard procedure?
Well, these are generally more complex, more targeted investigations. They might involve radiation like X-rays and CT scans or contrast agents. They use more resources, need specialized interpretation. They're ordered when the physician, Dr. Weir in this case, picks up something specific in the patient's history, their exam, maybe their vital signs or initial bloods. That raises a particular concern.
A clinical trigger is needed.
Exactly. Not every cellulitis patient needs their lungs imaged or detailed vascular mapping or a clot hunt. These are ordered to answer specific clinical questions.
Okay, let's go through them. Why might Dr. Weir request each one for a cellulitis patient? First, chest X-ray, CXR.
A chest X-ray looks at the lungs and heart. While cellulitis is usually in a limb, a CXR might be needed if there's concern the infection has become systemic. Maybe signs of pneumonia developing as a complication of sepsis, or perhaps assessing baseline heart and lung status in someone with known comorbidities, which is common in vascular patients.
Looking for spread or baseline info. Makes sense. Next, duplex Doppler ultrasound. This sounds very much like a vascular surgeon's territory.
Oh, absolutely. Duplex Doppler is key here. It's that non-invasive ultrasound that does two things. The duplex part shows the structure of the blood vessels, and the Doppler part listens to the blood flow inside them.
And why is that critical for cellulitis?
Two main reasons. First, differentiating from deep vein thrombosis. The symptoms, leg swelling, pain, redness, warmth, can look very similar to cellulitis. So ruling out a DVT is often necessary.
Okay, a look-alike condition.
But perhaps more importantly, patients admitted with severe cellulitis, especially if they're immobile from pain and swelling, are at higher risk of developing a DVT during their stay. The duplex is the go-to test to diagnose or rule out a DVT in the affected limb.
Ruling out a mimic or detecting a complication.
Got it.
How about magnetic resonance angiography, MRA?
MRA uses MRI technology specifically to get detailed pictures of blood vessels, both arteries and veins. Dr. Weir might order this if there's suspicion of underlying arterial disease, peripheral artery disease, for example. Poor arterial flow could be hindering healing or making the limb more prone to infection in the first place.
Okay, look at the in and flow pipes.
Exactly. And a big advantage of MRA is that it often doesn't need iodinated contrast dye. That's really useful for patients who might have kidney problems, which we'd know from the initial bloods, or an allergy to that type of contrast.
So detailed vessel imaging, especially if contrast is an issue. How does computed tomography angiography CTA compare then?
CTA also images blood vessels but uses CT scanning, usually with an iodine-based contrast injection. It gives excellent detail, often very quickly.
When would CTA be chosen over MRA?
Maybe if speed is critical, or if the patient can't have an MRI, perhaps they have certain metal implants. CTA also shows bones and other surrounding tissues well, but it involves radiation exposure, and you have the iodine contrast issue, again, potential allergy or kidney strain. So Dr. Weir weighs the pros and cons based on the specific clinical question and patient factors.
Similar goal vessel imaging, but different technology, different trade-offs.
Right.
And the last one, computed tomography pulmonary angiography, CTPA. That sounds lung-focused again.
It is. CTPA is a specific type of CT scan designed to look for blood clots in the pulmonary arteries, the arteries in the lungs. It's the main test for diagnosing a pulmonary embolism, or PE.
And why would a PE be suspected in a cellulitis patient?
It links back to that DVT risk we talked about. If a DVT forms in the leg and a piece breaks off, it can travel through the bloodstream and get lodged in the lungs. That's a PE, and it can be life-threatening.
The potential consequence of a DVT.
Exactly. So if a patient with cellulitis suddenly develops shortness of breath, chest pain, maybe a drop in oxygen levels, PE jumps high on the list of possibilities, and a CTPA is ordered to check for it urgently.
It really shows how these potential complications are all connected. The immobility links to DVT risk, which links to PE risk.
Precisely. The protocol anticipates these potential pathways and provides the tools to investigate them if needed.
Okay, let's quickly summarize the key points about these other investigations.
Sure. The main takeaway here is that advanced imaging like chest X-ray, Duplex Doppler, MRA, CTA, and CTPA are not routine for all cellulitis admissions. They require a specific request from Dr. Weir based on clinical suspicion.
Triggered by specific concerns.
Right. Concerns like possible pneumonia, ruling out or confirming a deep vein thrombosis, assessing underlying arterial disease, or diagnosing a suspected pulmonary embolism, all potential complications or contributing factors that need targeted investigation beyond the standard labs.
Okay, with assessments covered, let's move into Section 4, medication. This details the standard meds started on admission, understanding it can be adjusted. Point 4.1.1 specifies Clexane, which is enoxaparin, 40 milligrams subcutaneously once daily in the morning. Purpose: deep vein thrombosis prophylaxis. Why is clot prevention so standard here?
DVT prophylaxis is really a cornerstone of care for many hospitalized patients, but it's especially relevant for these cellulitis cases under a vascular surgeon. When you have severe cellulitis, particularly in a leg, the pain and swelling often mean the patient is barely moving.
Bedbound mostly.
Or very limited mobility, and that immobility is a huge risk factor for DVT. Blood flow slows down in the deep leg veins, that's venous stasis, and clots can form.
Virch's triad, stasis being one part.
Exactly. So enoxaparin, which is a low molecular weight heparin, is given to prevent those clots. It works by boosting the body's own anticoagulant system, specifically targeting a clotting factor called factor ZA. Blocking factor ZA stops the clotting cascade early on.
So it's proactively tackling a major, potentially life-threatening risk linked directly to the condition and being a nostril.
That's it. The 40 milligram dose is a standard prophylactic dose for medical patients at risk, given just under the skin once a day.
Okay, standard prevention. Point 4.1.2 moves to pain. Tramacet, 2 tablets 3 times a day. Cellulitis hurts a lot. What's in Tramacet and how does it work?
It really can be painful. Tramacet is a combination painkiller. It has 2 active ingredients, tramadol and paracetamol, which you might know as acetaminophen. Cellulitis causes pain through inflammation chemicals released, pressure from swelling on nerves. Tramadol is a synthetic opioid. It works partly like other opioids, binding to receptors in the brain and spinal cord to change pain perception, but it also has a weaker second action involving neurotransmitters like serotonin and norepinephrine, which also play a role in pain control pathways.
So a dual action from the tramadol part?
Kind of, yeah. And then paracetamol is your common non-opioid pain reliever, also helps with fever. Its exact mechanism is still debated, but it seems to work centrally, possibly affecting prostaglandin synthesis in the brain.
And putting them together.
Gives you better bang for your buck, often. Because they tackle pain through different mechanisms, you can get a synergistic effect, better relief than either one alone. The 2 tabs, 3 times a day schedule aims for consistent background pain control.
Makes sense. Combined approach for better relief. Point 4.1.3 covers the antibiotic. Ertapenem, brand name Invances. 1 gram stat immediately, then 1 gram once daily in the morning for 5 to 7 days. That sounds like a pretty hefty antibiotic choice up front. Why ertapenem?
Ertapenem is a carbapenem antibiotic. Carbapenems are known as big gun antibiotics because they have a very broad spectrum of activity. They kill a wide range of bacteria.
How do they work?
They're beta-lactams like penicillin, but more robust. They work by stopping bacteria from building their cell walls properly. They bind to essential proteins, penicillin-binding proteins involved in cell wall construction. Without a strong wall, the bacteria basically fall apart.
And why choose such a broad one here?
Because severe cellulitis, especially in patients with other health problems or vascular issues, can be caused by lots of different bugs: strep, staph, sometimes gram-negatives, even anaerobes. Starting with ertapenem gives you a good chance of hitting the likely culprit right away, even before you have specific culture results, which might take time or might not even grow anything.
Covering the bases quickly.
Exactly. And the dosing is smart too. That initial 1 gram stat dose gets therapeutic levels into the blood and tissues really fast, critical for hitting the infection hard. Then the once daily 1 gram dose is convenient, easier administration, better for potential outpatient therapy later on, perhaps.
So quick impact, then convenient maintenance, and the 5-7 days.
That's a pretty standard duration for uncomplicated cellulitis treatment these days, but obviously you always adjust based on how the patient is actually doing clinically.
Right. Clinical response guides duration. Okay, finally, point 4.1.4 offers a pain escalation option. Analgesia can be escalated to Targinact, which is oxycodone plus naloxone, 105 milligrams twice daily. When would you anticipate needing this step up?
You'd consider escalating if the patient's pain remains severe despite regular doses of Tramacet. If they're rating their pain high, if it's stopping them from resting or participating in essential care like elevation, you need something stronger, after assessing them, of course.
And Targinact provides that stronger relief. What is it?
Targinact combines oxycodone, which is a strong opioid agonist, works powerfully on opioid receptors for moderate to severe pain, definitely a step up from tramadol.
Okay, so that's the power hitter. But it also has naloxone. Isn't that the overdose reversal drug?
It is, but here it's doing something clever. When you take naloxone orally in this combined tablet, very little of it actually gets absorbed into your bloodstream. It mostly stays in the gut.
And what does it do there?
It acts as an opioid antagonist locally on the opioid receptors in the bowel wall. Opioids are notorious for causing constipation because they slow down gut motility by hitting those receptors.
Right, a common and miserable side effect.
Exactly. So the naloxone in Targinact blocks oxycodone's effect in the gut, helping to prevent or reduce that constipation. But because it's not absorbed systemically in large amounts, it doesn't significantly block the pain-relieving effect of the oxycodone in the brain and spinal cord.
Ah, that's clever. So it tackles the pain, but has a built-in mechanism to counteract a major side effect.
Precisely. It offers stronger analgesia with potentially better gastrointestinal tolerance compared to oxycodone alone, a practical approach for managing severe cellulitis pain.
Okay, let's quickly recap the standard medication lineup from this section.
You got it. Standard meds on admission include enoxaparin 40 milligrams daily for DVT prophylaxis, tackling that immobility clot risk.
Check.
Initial pain control with Tramacet, tramadol, paracetamol, 2 tabs 3 times a day.
Check.
Infection treatment with ertapenem, 1 gram stat, then 1 gram daily, usually for 5-7 days, providing broad bacterial coverage.
Check.
And an escalation option for severe pain using Targinact, oxycodone, naloxone, 105 milligrams twice daily, offering stronger relief with built-in constipation counteraction.
Okay, moving from meds to section 5, patient management and nursing care. Point 5.1 jumps out immediately marked critical, all caps. Elevate the patient's affected limb at all times to reduce edema. Why is constant elevation given such emphasis? It sounds simple, but achieving at all times must be challenging.
It is challenging, but it's marked critical because managing that swelling, the edema, is absolutely fundamental. In cellulitis, the inflammation makes capillaries leaky, fluid pours into the tissues, causing that massive swelling.
And the swelling itself causes problems.
Big problems. It increases pain, it can compress small blood vessels, impairing local circulation, and it generally hinders the healing process. Elevation is simply using gravity to help drain that excess fluid back towards the central circulation. Keeping the limb consistently above heart level helps both venous and lymphatic drainage work better.
Gravity as medicine. So how do you, as the nurse, actually achieve at all times? Patients need to sleep, eat, use the bathroom.
It takes dedication and, crucially, patient education. At all times means pillows, lots of pillows, stacked correctly under the limb in bed, maybe foam wedges or specific leg rests if you have them. It means constantly checking and reminding the patient to reposition if the limb slips down.
And getting the patient on board.
Absolutely vital. You need to explain why. Tell them, keeping your leg up will genuinely make it hurt less, it will help the swelling go down faster, and it helps the antibiotics get where they need to go. That motivation is key for compliance. And when they do need to sit up briefly, like for meals, guiding them to use that 45-degree semi-reclined position we'll see in the activity section helps minimize the time the leg is fully dependent. Maximize elevation whenever possible.
Constant elevation, the battle against swelling.
Yep.
Okay. Point 5.2. Assess vital signs every 6 hours. blood pressure, heart rate, respiratory rate, oxygen saturation, SpO2, temperature. Why this frequency? What are you watching for specifically?
6-hourly vitals are our early warning system. We're looking for any sign that the infection might be getting worse or becoming systemic, potentially tipping over into sepsis.
What kind of signs?
Well, a rising heart rate and falling blood pressure could signal shock. An increasing respiratory rate or falling O2 sats might point to lung involvement, maybe pneumonia, linking back to why a chest x-ray might be needed. Temperature trends are key. High fever is expected, but if it keeps climbing despite antibiotics or suddenly plummets, that can be a red flag for severe sepsis. Checking every 6 hours lets you spot these trends early and escalate care quickly if needed.
Looking for those sepsis warning signs. Got it. Another critical point, 5.3. Do not apply a blood pressure cuff or do venipuncture on the affected limb. Why absolutely avoid these on the cellulitis limb?
Again, critical for patient comfort and preventing harm. Think about inflating a BP cuff on an already swollen, painful, inflamed limb. It's going to hurt a lot. It could theoretically worsen the swelling or tissue damage, and the reading might not even be accurate because of the edema.
Makes sense. And venipuncture. Drawing blood or putting in a line.
Risky. Poking holes in infected skin could potentially drive bacteria deeper, maybe even into the bloodstream causing bacteremia. Plus, finding a vein in a swollen limb is difficult and painful. So, the rule is simple. Use the other arm or another site. Protect the affected limb from any unnecessary trauma or risk of spreading infection.
Protect the affected limb. Clear. Point 5.4 is broader. Complete your clinical assessment of the patient. And it breaks this down. 5.4.1. Assess and document allergies, mentioning iodine and antibiotics specifically. Why is this check so vital before treatments start?
Allergy assessment is patient safety 101. You absolutely must know what a patient is allergic to before you give them any medication or apply any product. Reactions can range from mild rashes to life-threatening anaphylaxis.
Obvious for antibiotics like ertapenem?
Yes, but also for things like iodine. As we'll see in wound care, an iodine dressing like Inodine is mentioned. If the patient's allergic, you can't use it. Failing to check and document allergies properly is a major safety risk. It directly dictates your treatment choices.
Directly impacts meds and wound care. Okay. Point 5.4.2 follows. Assess and document current medication, highlighting anticoagulants, antiplatelets. Why the net for the full home med list?
Knowing all the patient's current meds is crucial for several reasons. First, interactions. Are any of their home meds going to clash with the new ones? We're starting the ertapenem, the Tramacet, the enoxaparin. Some interactions can be dangerous or make drugs less effective.
Okay, avoiding clashes.
Second, it tells you about their underlying health. If they're on meds for heart failure, diabetes, kidney disease, that gives you the bigger picture of their overall health status and potential vulnerabilities. And the examples given, anticoagulants, antiplatelets, are critical. If they're already on blood thinners, you absolutely need to know that, especially since we're adding enoxaparin. It affects their bleeding risk, decisions about procedures.
Seeing the whole patient, their conditions, interactions, and specific risks like bleeding. Got it. Then 5.4.3 covers evaluating circulation. Right. Palpate pulses, assess Doppler flow, evaluate color and temperature. Why is checking the circulation in the affected limb so important?
Because severe cellulitis itself, with all that swelling, can sometimes squeeze blood vessels and compromise flow. Plus, many patients with cellulitis, especially under a vascular surgeon, have underlying vascular disease anyway, maybe venous insufficiency making them prone to it, or peripheral artery disease reducing inflow.
So you need to know the limb's baseline supply.
Exactly, and you need to monitor for any worsening. Is ischemia, lack of blood flow, developing? Palpating pulses, like the ones on top of the foot, dorsalis pedis, or behind the ankle bone, posterior tibial, is the first step. Can you feel them? How strong are they?
And if you can't feel them, maybe because of the swelling.
That's when the handheld Doppler comes in. You use it to listen for the whooshing sound of arterial blood flow. Even if you can't feel the pulse, hearing a good Doppler signal is reassuring. You can listen for venous signals, too.
Using sound when touch fails.
Right, and then just looking and feeling. What's the color? Is it pale, bluish, mottled? That suggests poor perfusion. Is it overly hot from inflammation, or perhaps cool compared to the other limb, suggesting poor arterial flow? Comparing limbs is key. This whole assessment helps determine if the limb has enough blood supply to fight the infection and heal.
Combining touch, tech, and observation for a full circulatory picture. Point 5.5 is simple but vital. Keep the patient as comfortable as possible. What does this mean beyond just giving pain meds?
Comfort is holistic. Yes, effective pain meds are huge, but it's also about positioning. Maintaining that limb elevation helps reduce pain from swelling. Managing other symptoms, fever, maybe itching if the skin is stretched or dry. Providing a calm environment. Making sure they can reach things, call for help easily, or addressing their anxiety. Just being responsive. A comfortable patient rests better, copes better, heals better.
Holistic care. Point 5.6. Request the patient to remove any restrictive clothing. Why the specific instruction?
Because anything tight socks, trousers, elastic bands can act like a tourniquet on a swollen limb. It can block lymphatic and venous drainage, making the edema worse, increasing pain, and potentially restricting circulation. Getting rid of restrictive clothing allows better drainage and also lets you see and assess the limb properly. Simple, but important.
Don't impede drainage or assessment. Makes sense. Lastly, in this section, 5.7. Please request the patient to shower with chlorhexidine soap. Sponge bath if unable to shower. What's the aim of this initial wash?
Chlorhexidine is a good broad-spectrum antiseptic. The goal here is to reduce the amount of bacteria living on the skin surface, especially in and around the affected area. If there's a skin break that was the entry point for the infection, cleaning with chlorhexidine helps decontaminate that area. It improves overall skin hygiene, might reduce risk of spread, and just prepares the skin for whatever comes next, like dressings or bandages. Offering a sponge bath is just being practical. Some patients will be too unwell or in too much pain for a full shower initially.
An initial decontamination step.
Exactly. Basic but important skin hygiene in the context of infection.
Okay, let's quickly bring together the key points from this crucial patient management section.
Right. Section 5 covers essential nursing actions. Critical point number 1, constant limb elevation to fight edema using gravity.
Non-stop elevation.
Regular vital signs every 6 hours to catch any systemic decline early. Critical point number 2, strictly avoid BP cuffs and venipuncture on the affected limb.
Protect the limb.
Perform a thorough clinical assessment. Document allergies, iodine, antibiotics crucial, current meds, especially anticoagulants, and evaluate circulation comprehensively using pulses, Doppler, color, and temperature checks.
Assess thoroughly.
And then ensure patient comfort holistically, remove restrictive clothing, and perform an initial skin cleanse with chlorhexidine soap, adapting to a sponge bath if needed.
Okay, section 6 moves on to patient activity, outlining what patients should and shouldn't do. Point 6.1 starts restrictively. The patient should be restricted to bed rest in the first 12 hours after admission.
Yeah.
Why the initial lockdown?
Those first 12 hours are really about stabilization. The patient's likely in significant pain, the limb is very swollen, the IV antibiotics and pain relief are just starting to work. Strict bed rest serves a few purposes here.
I agree.
Primarily, it makes consistent, effective limb elevation much easier to achieve. Hard to keep your leg properly elevated if you're up and about. It also allows the patient to just rest, conserve energy while their body starts tackling the infection. And it lets the clinical team monitor their initial response and vitals closely without activity clouding the picture.
So, prioritize rest and elevation while treatment gets going. Point 6.2 reinforces this. The patient should avoid sitting upright and may sit at an angle of 45 degrees when eating or drinking. This seems directly linked to protecting that elevation goal.
It is, absolutely. It's a practical clarification of the elevation rule. Sitting bolt upright, especially in a chair, means the affected leg dangles down, completely dependent. Gravity works against you, swelling worsens.
Undoing the benefit of elevation.
Exactly. Allowing them to sit up partially at that 45-degree angle is a compromise. It lets them eat or drink more comfortably than lying flat, but still keeps the limb somewhat elevated compared to being fully upright, minimizing that harmful, dependent pooling of fluid.
A practical modification. Then, point 6.3 signals a major shift. Patients should be encouraged to ambulate frequently, exemplary short walks every 1-2 hours, and avoid prolonged sitting or standing still once compression is applied. Wow, from bed rest to walking every couple of hours. Why the big change, and why is it tied specifically to after compression starts?
This marks the transition from the acute phase to more active recovery. Once you get effective compression bandages or hosiery on the limb, which we'll discuss next, that external support helps control the edema and supports the veins even when the patient is upright.
So the compression makes activity safe.
Safer and beneficial. With compression providing support, walking becomes really helpful. Why? The calf muscle pump. When you walk, your calf muscles contract and squeeze the deep veins, actively pumping blood back up towards the heart. It's like a secondary heart in your legs.
Activating the pump.
Yes. Frequent short walks are fantastic for boosting circulation, preventing blood from stagnating, which reduces DVT risk further, helping lymphatic drainage, and preventing stiffness. But the key is after compression. Walking around with a massively swollen leg without support would likely just make the swelling worse. And notice it says avoid prolonged sitting or standing still even with compression. Static positions aren't great. Keep moving, frequently but briefly.
Controlled activity, leveraging the body's own pump, enabled by compression. Makes sense. Point 6.4 is blunt. Patients should be actively discouraged from smoking. Why is smoking singled out so strongly?
Because smoking is absolutely disastrous for circulation and healing. It directly fights against everything else we're trying to achieve. Nicotine is a potent vasoconstrictor. It clamps down blood vessels.
Reducing blood flow.
Exactly. Reduced blood flow to a limb already stressed by infection and inflammation. That's terrible. Less oxygen, fewer nutrients get to the tissues that are trying to heal and fight bacteria. Plus, carbon monoxide in smoke messes with oxygen transport. Smoking impairs immune function. It's just bad news all around for healing.
It actively undermines the treatment.
Completely. So actively discouraging it, maybe offering cessation support or nicotine replacement is a really important part of the care plan.
Okay, let's quickly recap the activity progression from Section 6.
Right. Patient activity starts with strict bed rest for the first 12 hours, limiting sitting angle to 45 degrees to maintain elevation during that acute phase. Then, crucially, once compression is on, the strategy shifts to encouraging frequent, short walks every 1-2 hours to activate the calf pump and boost circulation while avoiding prolonged static postures. And throughout, actively discouraging smoking is vital due to its profound negative effects on circulation and healing.
Which leads us perfectly into Section 7, compression. Clearly a major part of the strategy, especially for managing that edema long term. Point 7.1 says Dr. Weir requests compression bandages if the patient's arterial circulation is adequate. It also mentions needing to know the Africa bandage system via QR code. Why is checking arterial flow before compression so critical?
This is a huge safety point, arguably one of the most critical, especially with a vascular surgeon's protocol. Compression works by squeezing the limb from the outside. If the blood flow into the limb through the arteries is already poor, if the patient has significant peripheral artery disease, adding external pressure can squeeze those arteries even more.
Cutting off the blood supply.
Potentially, yes. It can reduce blood flow to critically low levels, causing tissue ischemia, damage, ulcers, even limb loss in the worst case. So you absolutely must confirm there's enough blood getting into the limb before you apply pressure designed to help fluid get out. Arterial assessment first is non-negotiable.
That's a stark warning. How is adequacy assessed here?
It starts with that clinical assessment we discussed back in 5.4.3, feeling for pulses, using the Doppler if needed, checking color and temperature. If those raise any red flags, or if the patient has strong risk factors for arterial disease, smoking history, diabetes, etc., then Dr. Weir might order more specific tests like an arterial duplex scan, maybe even an MRA or CTA from Section 3 to get a definitive picture of the arterial supply before deeming compression safe.
So clinical assessment first, potentially backed by imaging if needed, and the Africa bandage system.
That suggests a specific technique, likely a multi-layer system designed to provide graduated compression, higher pressure at the ankle, decreasing up the leg. These systems require proper training to apply correctly to achieve the desired pressure safely. The QR code likely links to training resources for that specific system.
A skilled application needed, but only after the safety check. Point 7.2 describes moving from bandages to hosiery. When edema has subsided sufficiently and a wound is not present, Dr. Weir requests an orthotist assessment for compression hosiery. Why the switch, and why involve an orthotist?
Bandages, especially multi-layer ones, are great for the acute phase when the limb size is changing rapidly as swelling goes down. They can be adjusted. But they need frequent reapplication, often daily, which isn't practical long-term. Once the swelling is significantly reduced and stable, and importantly, if there's no open wound needing dressings underneath, you generally don't wear hosiery over open wounds, then properly fitted compression hosiery is the way forward for long-term management.
More practical for daily life.
Much more. And the orthotist is the expert here. They specialize in measuring limbs accurately and fitting medical devices like compression garments. They ensure the patient gets the right size, length, style, and critically, the right pressure class of hosiery for their ongoing needs. A good fit is essential for both effectiveness and comfort, which drives compliance.
Bandages for acute, changing swelling, hosiery for stable, long-term management, fitted by a specialist. Got it. Point 7.3, get specific. Class 2 below knee, cotton compression hosiery is most often requested. Can you unpack Class 2 below knee and cotton?
Sure, Class 2 is a standard compression level. It means the stocking provides a pressure of roughly 23 to 32 millimeters of mercury, millimg at the ankle, gradually reducing up the leg. This is considered moderate to firm compression, effective for managing significant chronic venous issues and edema like you'd expect after severe cellulitis.
Okay, a specific therapeutic pressure range.
Below knee means the stocking only goes up to just below the knee. This is common because cellulitis often affects the lower leg, and this length supports the calf muscle pump effectively. It's also generally easier for patients to put on and tolerate than thigh highs.
Makes sense. And cotton.
That refers to the material. Cotton blends are often chosen for comfort. They tend to be more breathable and less irritating against the skin for all-day wear compared to purely synthetic materials, which can help with long-term adherence.
So specific pressure, common location, comfortable material. And then point 7.4 makes a very clear negative statement. Thromboembolism deterrent or anti-embolic hosiery is never requested. Why are TED stockings absolutely ruled out here?
This is a really important distinction for nurses to understand. TED stockings, or anti-embolism stockings, provide much lower compression, typically only 8 to 18 millimillig. Their main purpose is for non-ambulatory bed-bound patients, like immediately post-op, to prevent blood pooling in the calves while lying down. They do not provide the higher graduated pressure needed to actively manage significant edema in a patient who is up and walking around and likely has underlying venous problems contributing to their cellulitis.
So, wrong tool for the job.
Completely wrong tool. Using TEDs for edema management in an ambulatory patient recovering from cellulitis would be ineffective. They simply don't provide enough pressure or the right pressure profile. It's critical to use the correct therapeutic compression, like Class 2, prescribed for managing the edema itself.
A crucial difference in purpose and pressure. Good to clarify. Let's quickly recap the compression strategy.
Okay, compression, section 7 is key, but safety first. It starts with bandages, often a specific multi-layer system, but only after adequate arterial flow is confirmed to prevent harm.
Arterial check is mandatory.
Once swelling is down and stable and wounds are healed, the patient transitions to fitted compression hosiery, usually via an orthotist assessment. The typical choice is Class 2 below knee, cotton hosiery for effective, comfortable long-term management. And critically, TED stockings are never appropriate for this purpose. They're for non-ambulatory DVT prevention only, not edema management.
Okay. Section 8 deals with wound care, but only if there's an open wound associated with the cellulitis. Point 8.1, clean the skin around the wound with Prontosan. What's Prontosan, and why clean around first?
Prontosan is a common wound cleansing solution. It contains an antiseptic, polyhexanide, and a surfactant, betaine, to help clean and reduce bacteria. Cleaning the skin around the wound first is standard aseptic technique. You want to avoid dragging bacteria from the surrounding skin into the potentially cleaner wound bed, so you clean the periphery first.
Clean to dirty, essentially.
Okay.
Then point 8.2, clean the center of the wound with Prontosan. Why use it inside the wound too?
Because Prontosan also helps to remove debris, slough, dead tissue, and bacterial biofilm from the wound bed itself. A clean wound bed is essential for healing. The solution helps physically rinse away contaminants and provides antimicrobial action within the wound environment, preparing it for dressing.
Preparing the wound bed. Got it. Point 8.3 specifies the primary dressing. Apply inodine to the wound after confirming no iodine allergy. We flagged this allergy earlier. What is inodine?
Inodine is a dressing soaked in povidone iodine. Povidone iodine releases iodine slowly, providing broad-spectrum antiseptic action against bacteria, fungi, even spores, right at the wound surface. It's a common choice for potentially infected or contaminated wounds, but that iodine allergy check is crucial. It's an absolute contraindication.
So iodine provides the antimicrobial action if safe for the patient. Point 8.4 gives the backup plan. If allergic to iodine, Acticoat or another silver dressing can be applied. How do silver dressings work as the alternative?
Silver dressings are the main alternative antimicrobial category. They contain silver, which releases silver ions when it contacts wound fluid. These silver ions are toxic to a broad range of microbes. They disrupt cell walls, interfere with metabolism, damage DNA. Acticoat is one specific brand using a form of silver, so if iodine is out due to allergy, silver provides that needed antimicrobial effect.
Silver takes over if iodine is a no-go. Makes sense. Point 8.5 addresses wounds that are producing a lot of fluid. Wounds with large volume exudate should have a secondary layer of mesorb or other absorptive dressing on top. Why this extra layer?
Some wounds, especially inflamed or infected ones, leak a lot of fluid exudate. If that fluid just sits there, it can soak and damage the healthy skin around the wound. We call that maceration. It also makes the area prone to more infection and means you'd have to change dressings constantly.
So the secondary dressing mops it up.
Exactly. An absorptive dressing like Mesorb is put on top of the primary dressing, the inidine or silver, to soak up that excess exudate, lock it away, protect the surrounding skin, maintain a healthier moisture balance in the wound itself, and allow the dressing to stay on longer between changes.
Managing the moisture. Okay, 0.8, 0.6 loops back.
Yeah.
Compression bandages can then be applied with the African bandage system. This just confirms the order. Wound care first, then compression.
Correct. You need that clean, dressed wound environment established before you apply the external pressure of the bandages.
Dress first, compress second. And 0.8.7 emphasizes duration. Graduated compression bandages should be used until the wound has healed completely. Why keep the compression going right until the end?
Because managing the edema is fundamental to allowing the wound to heal, especially on a lower limb prone to venous issues. Swelling impairs healing, reduces oxygen delivery, nutrient supply, waste removal. By keeping graduated compression on consistently, you control the edema, support the venous return, and create a much better environment for the body's repair processes to work effectively. Compression isn't just for initial swelling, it's an active part of the wound healing therapy itself in these cases.
Compression as a healing promoter, not just swelling reducer.
Got it.
Let's recap wound care quickly.
Okay, if a wound is present, section 8, the steps are: clean around, then clean the center with Prontosan. Apply a primary antimicrobial dressing, inidine, if no iodine allergy, or a silver dressing, like Acticoat if allergic. If there's lots of exudate, add a secondary absorptive layer like Mesorb. Then apply the graduated compression bandages using the specified system. And importantly, continue that graduated compression until the wound is fully healed to optimize the healing environment.
We've covered a lot of ground now. From arrival checks, assessments, labs, specific imaging, the medication strategy, those critical management points like elevation, the activity plan, the detailed compression approach, and now wound care. Before hitting discharge, maybe let's just pull back for a second and look at the bigger picture, how these sections all fit together.
Yeah, that's a good idea. When you look at the whole protocol, you really see how it layers safety, thorough assessment, and very targeted interventions, all with that vascular lens.
Right. It starts with those absolute safety basics, identity, allergies, current meds. You can't do anything else safely without those.
Exactly. Then you have the assessments. The blood's telling you about infection, kidneys, blood counts, the potential for imaging if you suspect DVT or PE or need to check arterial flow. That assessment phase directly drives what you do next.
Like knowing kidney function affects drug doses, checking arterial flow gates, the use of compression.
Spot on. And the non-drug interventions are just as critical. That constant limb elevation isn't just a nice to have. It's labeled critical because it directly fights the pathophysiology of the edema, which is often worse in patients with underlying venous problems.
And the activity plan reflects that too. Rest and elevation first, then mobilize with the support of compression using the calf pump. Very logical progression.
It is. And the compression section itself is so specific. The need for arterial checks, the class 2 preference, the explicit no TEDS rule, it all reinforces the need for therapeutic compression tailored to managing the underlying circulatory issues safely and effectively.
And the wound care integrates smoothly, using specific antimicrobials based on allergy, managing exudate, and ensuring compression continues over the dressed wound to promote healing.
It all interconnects. Assessment informs intervention, management supports recovery, compression underpins activity and healing. It's a cohesive strategy, not just a list of tasks.
It feels like a very thought-through plan for a complex patient group. Understanding that whole structure, not just the individual steps, must be really valuable for the nurses implementing it.
Absolutely. Knowing the why makes you much more effective in delivering the care, educating the patient, and spotting when things might be deviating from the plan.
Okay, that sets us up for the final phase, Section 9, discharge arrangements. What happens when the patient is ready to leave? Point 9.1 is very direct. Please make sure the patient has received their compression hosiery before discharge. Why is physically having the stockings before walking out the door so important?
This is about preventing immediate relapse and ensuring long-term success. Compression hosiery is vital for managing the chronic edema that often underlies recurrent cellulitis, especially with venous insufficiency. If they leave without it, The swelling that was controlled in hospital will likely come roaring back as soon as they're upright and active at home.
Undoing all the progress made.
Pretty much, and potentially increasing the risk of the cellulitis returning quickly. Having the hosiery in hand, knowing how to put it on, ideally having been taught by the orthotist who supplied it as per section 7.2, means they can start wearing it immediately. It ensures that continuity of essential therapy.
Immediate continuation of preventative care. Makes sense. Point 9.2 says Dr. Weir supplies certain items. First, 9.2.1, a discharge protocol. What's typically in this for the patient?
Think of it as their personalized instruction manual for home. It would summarize their diagnosis, treatment in hospital, list all their discharge medications, clearly name, dose, timing, how long to take them. It'd give instructions on activity, wound care if they still have a wound, how to use and care for their compression hosiery, list warning signs, things to look out for that mean they need to seek help, and details of any follow-up appointments. Clear written instructions are key for patient understanding and adherence.
The roadmap for recovery at home.
Yeah.
Point 9.2.2 is a script for pentoxifylline and pain medication. We know about pain meds, but what's pentoxifylline? Why might that be prescribed now?
Pentoxifylline is interesting. It's often used in patients with peripheral artery disease. It's called a hemorrhagic agent, basically. It makes blood flow a bit better. It reduces blood viscosity, makes red blood cells a bit more flexible.
So it helps blood squeeze through tight spots.
That's the idea, especially in the tiny vessels, the microcirculation. For patients under a vascular surgeon, who often have underlying circulatory compromise, pentoxifylline might be added long-term to try and improve tissue perfusion. It's not treating the acute cellulitis, but it might support ongoing healing and maybe reduce future issues related to poor blood flow. The pain med script just acknowledges that ongoing pain relief is often still needed after discharge, tailored to their situation.
So pentoxifylline possibly targeting underlying circulation plus ongoing pain relief.
Yeah.
Got it. And 9.2.3 is a referral letter to a wound care specialist, but only if required, for intensive wound care and graduated compression bandages. When would this referral kick in?
This is for patients going home who still have an open wound that needs more than basic care, or who still need skilled application of compression bandages rather than being ready for hosiery. Maybe the wound is large, complex, slow healing. Maybe it's a chronic venous ulcer that got infected. Or maybe they just can't manage hosiery yet. A referral to a specialist wound clinic ensures they get that expert ongoing management, debridement, advanced dressings, continued specialized compression seamlessly in the community.
Handing over complex ongoing needs to the specialists. Okay. Finally, the protocol notes. Please also refer to the general admission protocol and blood pressure monitoring protocol. What does this tell us?
It's just a reminder that this specific cellulitis protocol doesn't exist in a vacuum. It slots into the hospital's wider set of standard procedures. There will be a general protocol covering things all admissions need: paperwork, ID bands, consents. There'll be a standard protocol for how to measure and document blood pressure properly. This specialized cellulitis protocol builds on those basics, adding the specific requirements for this condition. It integrates, it doesn't replace those general standards.
Puts it in context.
Right, exactly. It's a specific pathway within the hospital's overall system.
Okay, we have now journeyed through this entire, very detailed cellulitis admission protocol from Dr. Weir. From the moment of arrival with identity and welcome, through assessments, labs, and potential imaging, this specific medication regimen covering infection, pain, DVT risk, the absolutely critical management strategies like elevation and site restrictions, the carefully phased activity plan linked to compression, the very nuanced approach to compression therapy itself, including safety checks and specific types, the steps for wound care when needed, and finally, the key elements for a safe and effective discharge. It's clearly way more than a simple checklist.
It really is a comprehensive strategy. And for you, the specialist nurse, understanding this level of detail, the why behind the UKE and CRP, the rationale for ertapenem, the absolute necessity of that arterial check before compression, the reason TEDs are forbidden, it's that understanding that empowers you.
How so?
It lets you provide truly informed care. You can anticipate problems, educate patients and families much more effectively because you understand the logic, and you can recognize subtle deviations or complications earlier. It moves practice beyond just following orders to actively managing the patient based on deep clinical understanding.
Mastering the logic, not just the steps. So as you listening reflect on this deep dive into Dr. Weir's protocol, here's something to mull over. We talked about how crucial things like constant limb elevation and consistent compression hosiery use are, especially long-term. Thinking practically, What are the biggest hurdles you actually see patients facing in sticking to these vital steps after they leave the hospital?
Mm.
And how can you, as a specialist nurse, proactively equip them during their admission to overcome those specific real-world barriers they'll face at home?
Yeah, bridging that gap between the ideal protocol in hospital and the messy reality of life at home, that's where expert nursing makes a huge difference in achieving those lasting good outcomes.